Okay, so for the chief complaint for this patient presented with abdominal pain. Um, so would you like me to go on for the HPI or would you like to dissect the abdominal pain right now?
Why don't you take us through the HPI here to start?
Okay, okay. So this was an 18-year-old female who had presented with the sudden severe non-localized abdominal pain that had started 3 hours ago during a family gathering. It's a cramping pain, it's intermittent, coming every 10 minutes or so, no radiation, associated symptoms, including vomiting as well as body diarrhea, and there are no relieving factors.
All right. That's a great start. And just to confirm, did you say that there was or was not diarrhea?
Yeah, so there was bloody diarrhea associated in addition to vomiting and nausea.
All right, all right. Well, I think that this is a really rich place to start. We sort of have two um, uh, close by and very overlapping chief concerns up front, which is we have the finding of abdominal pain, and then we also have we also have some features, for example, the nausea, the vomiting, and the bloody diarrhea that can help potentially point us into some direction in terms of localizing the etiology of the abdominal pain, right? Whenever we have acute abdominal pain, we've gone through the framework several times before, but we'll just review it again for a systematic approach as we can think about some of the life-threatening causes of abdominal pain using the VIPO framework or VIPO. V stands for vascular causes, and within vascular, we're going to think about two MIs and two As. The two MIs are mesenteric ischemia and myocardial infarction, both of which are probably less likely in a young, otherwise, as far as we know, healthy person. We can have I's, which could be itis, which could be any organ in the abdomen. You add itis onto it, and that can happen. Things like appendicitis, cholecystitis, colitis, pancreatitis. P for perforation, and then O for obstruction. And then whenever we have somebody who is of childbearing age who potentially may be able to conceive a pregnancy, I always add an E onto the end of VIPO. So VIPO plus the E, with the E standing for ectopic pregnancy. So I think that would sort of be the general framework that we would think about for life-threatening causes now, but we have these interesting modifying factors of the bloody diarrhea, the nausea, and the vomiting. I will say that anything on that list, VIPOE, anything on that list can come with nausea and vomiting, right? Any intra-abdominal pathology can make an individual experience nausea and vomiting. But I think the bloody diarrhea offers a potentially interesting signal for us here. So I'll turn it over to you, Sharmi, to sort of take us through that part of it, and then anything else that you would add to the abdominal pain in general.
Oh, yeah, no, I love that. I love like starting with no misdiagnoses, and I love the VIPO framework as around the ectopic pregnancy for any woman, as you mentioned. I think like that's such a great way of thinking about it. And yeah, and I think like the cramming nature of the abdominal pain is quite interesting. So I think like pregnancy, menses, those things can also more like pelvic organs can have the cramping nature to it. And as you mentioned, like the that setting aside and like focusing on the bloody diarrhea. So, with diarrhea, we often like think about like acute diarrhea and chronic diarrhea. Whenever I hear bloody, I think inflammation. That's how it translates in my mind in terms of like diarrhea that is like more inflammatory in natures. With like acuity of it, now that it seems like it started like 3 hours ago. If that is were to the case, then like infections tends to take a priority. And in terms of like other inflammatory diarrheas other than infection that can be acute, you mentioned like ischemia. I often like think about like ischemic colitis or the radiation induced. However, that's like really not this patient, 18-year-old, unless like, she has historic like vasculopathy of some sort that confers an increased risk, which again, I think something that would come up in either past medical history or this might be the first time she's seeing here. 18-year-olds tend to not see doctors that often. I think like and the last thing I would say, chronic diarrheas have to start somewhere. And so if she has like some sort of like immunodeficiency to begin with, like, or like IBD. She's like good age for that. So it has to kind of start somewhere, sometimes with like bloody bowel movements. So that's another one to inflammatory bowel diseases to think about, like infiltrative diseases like lymphomas, and then like infections like HIV, CMV, those things tend to be more chronic in nature. So again, like I think acute infection is number one, number two, number three, and then all of the other ones tend to be secondary. All right, everyone, would love to hear some more.
Okay, so for the past medical history for this patient, she doesn't have any remarkable past medical history, except that the family says that this is not the first time that she had bloody diarrhea, but she had never presented to the hospital before. Regarding her past family history, it's pretty interesting. So the family survey included 42 family members from 4 generations. 9 family members of those had mucocutaneous pigmentation, as well as multiple hamartomatous polyps that were documented on hospital files. There were no sexual differences between the family members. And so we started thinking about autosomal dominant genetic diseases in here. And then 3 of the 9 family members, including the patient's mother, as well as sister and brother, all died of colorectal cancer.
Amazing, Ibrahim. For the sake of time, this is a super rich background, and also for the sake of time, do you mind taking us through the physical exam here?
Yep, of course. Okay, so for the physical examination for this lady, she had pigmentation of the oral cavity. The abdomen was less distended with increased bowel sounds, tenderness, as well as hypertympanic on percussion. The digital rectal examination revealed normal limits. And then I'm gonna go on to the blood investigations again for the time's sake. She had anemia, and then she also had abdominal x-ray, but I think I'm gonna keep it for later.
All right. Wow. Whoever took that family history, hats off to them. So that's like a very rich generational history that shows propensity for colorectal cancer in addition to polyps. So thinking about like different congenital or hereditary diseases that can cause a lot of polyps, like I think Lynch syndrome is one of them. There are like a couple of different ones, and it sounds like this is something that this patient can also be at increased risk for. And kind of like thinking about like, hey, at baseline, a lot of her and family members have had polyps. So what can happen to polyps? Polyps can bleed. So I wonder if like that is kind of part of the symptomatology that we can see. If there is a breakage in the mucosa, they're at higher risk of infections, which is another possibility here as well. And then the malignancy. So, I think this is the patient that you're going to do a lot more workup. And at the end, I think this is a person with that history. If they're coming in, I'm going to get GI on board a lot faster. And this is someone that I would think like, early scopes are indicated, especially if you think about the way sometimes to think about it is like, who was the earliest family member that had colorectal cancer, and they want to start do things even sooner than that. Pass the mic to the one and only Jack.
I think no, this is a super interesting turn here. I think one of the things that sort of competing with in my head, I think, as a couple individuals have mentioned in the chat, is the possibility of underlying Peutz-Jeghers syndrome, right? The autosomal dominant disease characterized by mucocutaneous pigmentation, hamartomatous polyps, as well as an increased risk of many gastrointestinal cancers, mainly colorectal cancer. So that's certainly looming in the background here. But I think, Sharmeen, as you were alluding to, how can we then track those findings onto bloody diarrhea? And I totally agree with you that a polyp, that a potential bleeding polyp is very high on that list. One of the things that I'm contending with here is that I usually think about polyps or lower or sort of middle GI bleeds from things like polyps or other abnormal tissue formations as usually being a painless process, right? If we think about a diverticular bleed, for example, that's usually painless bleeding. And if a polyp happens to have abnormal vasculature on its surface, there's the possibility I would say I would expect that most often, if it's just the polyp that is bleeding, to be a painless process. And so the introduction of pain here makes me wonder about the possibility of complications of polyps, right? One of the underlying colonic masses. One of the things that can be a complication of polyps in addition to bleeding is that those structural malformations, if it's a large polyp within the colon, can cause obstruction. They can also be a nidus for things like intussusception or other mucosal abnormalities. And then if there's a mass there that has developed, which again would be rare but not impossible in someone who's 18 years old, particularly with this baseline underlying cancer risk, we could also think about that mass potentially causing a much more sinister complication in the intra-abdominal space, such as a perforation. So the fact that we have this hypertympany on exam here, right, tells us that there is probably more gas than normal somewhere within the abdomen. If that gas is in the lumen of the GI tract, the probability of obstruction goes up much, much higher. And certainly a polyp can be an underlying nidus or almost can be a nidus for developing obstruction.
Right.
That can happen if the polyp is potentially obstructing the lumen itself. But again, the polyp can also be an anchor point for other complications to develop, whether that's volvulus or intussusception, for example. And certainly if that polyp gets caught in some sort of abnormal sort of knot tying within the GI tract, that could potentially cause enough mucosal damage to lead to bleeding overall. So I think we certainly have, I think, some very, very interesting family history here to sort of contend with. And I think then trying to say, okay, how can that family history and those underlying risk factors map onto the presence of pain and hypertympany here? And I think obstruction starts to come up potentially higher if there are lots of polyps there throughout the GI tract, along with all the things that you mentioned from the get-go, Sharmeen, in terms of sort of acute onset bloody diarrhea, still prioritizing infectious causes, but expanding the spotlight to include obstruction, with these polyps being the nidus of it, either again through the luminal obstruction or an anchor point for some of these other more not tying problems within the GI tract. All right, Ibrahim, why don't you give us a little bit more? This is a phenomenal case.
Right. So just to fill in the gaps for whoever's doing the scribe, the medications were non-remarkable. Social history was non-remarkable. Allergies, no known allergies. For her temperature, she had a temperature of 37.9, heart rate 113, blood pressure was 90/85, and respiratory rate was 30. Saturation, 94. And then all of the other exams, other than the ones we've already mentioned, were not remarkable, right? And then she was also anemic on presentation. So the patient had a hemoglobin level of 7.6. Right, and then sodium was 147. And potassium was 3.3, and all others were non-remarkable. EKG was sinus tachycardia. And then on abdominal X-ray, the patient had small bowel obstruction. So this patient underwent emergency expiratory laparotomy, and then a specimen was sent for histopathological examination and was described as a typical hamartomatous polyp. She was given an intravenous broad-spectrum antibiotic as well as analgesic drugs for 5 days. Post-operatively, the patient had satisfactory progress. And then 2 months later, the diagnostic endoscopy was performed, and there were multiple polyps in the large bowel measuring 5 to 15 millimeters without any features of intussusceptions. And then would you like me to go on for the histopathological result?
Yeah, but I think we can just like reflect on this, Aleko. Thanks so much. This is
Okay.
such a rich discussion. Uh, Jack, what are your thoughts?
Yeah, I mean, I think it's a both a surprising and I would say unsurprising term, right? Surprising in the setting of thinking about somebody so young presenting with the small bowel obstruction, but in looking through the background risk factors here, it makes perfect sense. I think one of the things that I'm super curious about to learn from Ibrahim with is what they thought the underlying mechanism of the small bowel obstruction was. Was it just that the polyp was so big that it blocked off the GI tract, or if it served as a possible anchor point for the stomach to sort of twist around itself, or sorry, not the stomach, for the small bowel to twist around itself or cause some other abnormal kink that ultimately led to the small bowel obstruction. I think the endoscopy findings and the sort of histology track with what we had seen before in this very dense family history. I think it's a good reminder. Usually we think about polyps as benign lesions, and on the malignancy scale they are, but they can certainly have non-cancerous malignant outcomes associated with them. And I think that this is a great example of that. In terms of what the histopathology is going to show, I think that I can't go further than really what like my understanding of like the normal polyp spectrum is. But certainly am concerned, given the family history, the possibility of underlying Peutz-Jeghers disease, that this may be a malignant transformation or pre-malignant that may really increase her risk of subsequent malignant neoplasms going forward. But yeah, Charmaine, what are your thoughts?
Yeah, no, I 100% agree with you. Just to kind of like practice our thinking about small bowel obstructions. And I know, and as Jack was talking through, he was like alluding to this that most common causes of small bowel obstructions tends to be like adhesions, and someone who's already had like prior abdominal surgeries, and a lot of the times with small bowels, we tend to medically manage them unless there's like underlying mass or something like in this patient that they were suspecting. So like kind of the first pass of adhesions, hernias, both external and internal hernias, and then like it tends to be more malignancy in adults. And then you get to the rare causes of small bowel obstructions, and that's like, we're concerned here for intussusception or volvulus, gallstones, all of those things come into play. Yeah, I'm right there with you. I think, as you guys are mentioned, again, the hereditary syndrome, Peutz-Jeghers is good thoughts here. So yeah, we're curious to see what you all found out, Ephraim.
Okay, so on histopathological examination of the polyp, it was characteristic of Peutz-Jeghers syndrome, consisting of a branching framework of connective tissue and smooth muscle, lined by the normal intestinal epithelium. And then the family history further clued us into the diagnosis and actually confirmed Peutz-Jeghers syndrome. And then eventually this patient was actually scheduled for follow-up for repeat colonoscopy 3 years later, as well as annual screening for associated cancers with Peutz-Jeghers syndrome.
Wow. What a great case. Ibrahim, thank you so much for bringing this. I think it sits at that wonderful intersection between both the common and the rare, which always makes for really valuable learning. And I just wanted to point out one last teaching point that I think is really important that you mentioned here, but just to sort of elevate it for the group. You mentioned that that she was scheduled for regular follow-up colonoscopy screenings as well as other cancer screenings overall. And I think a lot of times, at least like when I recall learning about Peutz-Jeghers, the center of gravity and the spotlight was on the increased risk of gastrointestinal cancers, but especially in a young female, it's really important to be aware of the fact that the cancer risk is really quite high in many extra-intestinal cancers as well. So there's a very high risk of breast cancer, a very high risk of ovarian cancer and cervical cancers. And I think so I just wanted to elevate and highlight the fact that you mentioned other cancer screening as well, to put some names to those ones, thinking about whether or not, and I don't know the data on this, but I think it would cue me to think about whether or not from a primary care perspective, it's valuable to start thinking about other screening for, or I should say early screening for these other cancers, particularly breast, cervical, and ovarian cancer, in addition to the intestinal cancers that you mentioned, because those are still quite common in the population overall, and even more common in individuals with this underlying mutation.
Boom. What a great point. Yeah, thanks, Orion. What a fascinating case. And thank you, Leah, for scribing. And we can't wait to hear your teaching points, Sarah. Thanks so much, Ibrahim.
Yeah, thank you so much, Abraham, for the case. It's always like a great reminder of these like rare genetic conditions and their complications. So I love doing the teaching points for this. So the way that we started out this discussion was thinking about our common frameworks for abdominal pain and diarrhea and kind of adding additions based on the features of this case. So for our VIPO framework for life-threatening abdominal pain, we decided to add an E for ectopic pregnancy, since this was a person of childbearing age who can have an ectopic. And then for our approach to diarrhea, which we would categorize into acute or chronic, this patient had acute bloody diarrhea, which is equivalent to inflammatory diarrhea. And in this case, we can consider infection, vascular, or the first presentation of a chronic inflammatory diarrhea cause, such as something like IBD or something like an infiltrative disease like CMV. And then something that was a huge feature of this case was that the patient had an extensive family history of polyps and colorectal cancer. And so the differential can include genetic conditions such as Poits-Jaeger, Cowden, Ruvalcaba, and Lynch syndromes. And then in terms of the presentation for this patient, acutely, we can consider a simple bleeding polyp if there is there doesn't seem to be any complications, or other complications of these kinds of polyps if there is pain or tympany on exam. And so these complications can include one, mass effect, so it can cause obstruction of the intestinal lumen or perforation. Two, there could be a lead point somewhere that would lead to volvulus or intussusception. Three, there could be a malignancy. And then four, there could be an infection. And then with this extensive family history, this patient will require a very thorough GI workup, including a scope, as well as a thorough history, including what's the youngest age that someone in their family had onset of colorectal cancer. It was found on imaging that this patient had a small bowel obstruction. And so the most common cause of obstruction would be adhesions, and the less common would be malignancy, intussusception, and gallstones, which was the case in this patient's presentation. And then finally, we found through pathology that this patient had Poits-Jaeger syndrome, which it's a great reminder that this patient will require yearly screening for colorectal cancer after they leave the hospital. And also they will require screening for other common cancers in these patients, including breast, cervical, ovarian, and other GI cancers. So again, thank you for this case. I love learning about it. Yeah, thank you for the learning.
Boom, Sarah, that was fantastic. Thank you. Thanks, everyone. This was so great. Such good learning. We'll see you next time. Bye all.
Bye, everyone.